So it's interesting to be here in Vancouver talking about treatment scale-up, especially having just completed at least an initial draft of this paper jointly with two people who are here in the audience, and they are Dan Klein and Anna Burstein. Are you able to wave your hands wherever you are? There's Dan.
Yeah.
Anna? Okay. And the lead author on the paper is Gesine Meyer-Rath, who is based in South Africa and works closely. She's at Boston University. She's at the HERO Institute in South Africa, the Health Economics Research Office, and she works closely with the South African Ministry of Finance in estimating their costs of scale-up. So this model is an input to that process. I want to thank all of these people. We're going to talk a little bit in these 10 minutes about the epidemiological model, a little tiny bit. Anna and Dan are here to answer questions on that. What I think is novel about the model is partly the epidemiology part, which is an agent-based model, but also the economic structure that we placed around that in order to estimate for the Ministry of Finance and for the world at large what the possible cost of scale-up might be. So the epidemiological model, I'm not extraordinarily well placed to describe, but the key thing about it to remember is that it's an agent-based model. It's not a model with compartments that use differential equations to model the course of the epidemic, the way I think many of the models you've seen in the last couple of days have been. Brian Williams frequently works with those types of models, although Brian can work with any type of model that he wants. But the agent-based models have additional complexity, but they have additional power because of their ability to model many interactions far more than can be captured in a compartmental model. Jorge gave a wonderful presentation not only about the concept of the cascade in Mexico, but about the variability of the cascade. A very important thing is that we understand how it varies, and these models aren't very useful unless they can capture that cascade with some degree of verisimilitude. Furthermore, they should be able to be adjustable to capture the kinds of variations that Jorge described, and I'm sure Dan could speak to how the EMOD model could do that. The EMOD team in Seattle is based at Intellectual Ventures at the Institute for Disease Modeling. They used these 12 scenarios to describe the potential policies that could be undertaken in South Africa to scale up treatment. The rows represent different degrees of ambition, and also typically more, in some cases, more targeted ways to scale up. So you'll see the current guidelines represent CD4 threshold of 350 and below. Universal test and treat would be to have no threshold whatsoever. Eligibility less than 500 is obvious. Discordant couples and pregnant women. These are the last two then are prioritized ways to go. And as you can see with any one of these, the option would be to have a relatively modest expansion speed to do prioritized expansion, or to uniformly spread the expansion across the entire population. So the way this particular modeling effort worked was that these scenarios were generated out into the year 2033. So the projections were from 2013 to 2033 for all 12 scenarios. And then they arrived in a package from Seattle to Gesine and I, and we worked on them to try to say, what would it cost to accomplish these objectives? So we had to think about the fact that you need to have people coming to treatment, and you need to have them adhering to the degree that's being modeled in the model. So what does it take to do that? We know that currently the South African government and the population are achieving a certain degree of adherence, a certain degree of quality of care, and achieving a certain cascade, certain outcomes. All of that's captured in the status quo model because the model was calibrated to that current reality. So the question is, what happens when you try to do a whole lot more than you're doing now? Some of these scenarios talk about doubling and more than doubling the number of patients. So we need to worry about cost. Now, you've heard a lot about cost, but I think one thing you haven't heard much about is the possibility that in order to treat a whole lot more people, we're going to have to get facilities a lot closer to each individual patient. You have heard, I think, allusion to the distance elasticity that Till Bernenhausen and his colleagues have found in KwaZulu-Natal, where every additional kilometer of distance from the facility led to a statistically significant and quite sharp decline in health-seeking behavior. So this cost curve right here comes from data that was collected by the Clinton Health Access Initiative on 161 facilities in 5 countries. And the cost curve shows that half of the facilities, the half that are smaller than that median vertical line, had much higher costs than the other half. And those are exactly the types of facilities that are going to be needed in order to reach the scale-up objectives. So that's the supply side. On the demand side, we also have to be concerned. And I very much appreciated the presentation by Ava, who talked about all of the difficulties with starting people on treatment who don't yet want to start on treatment. The status quo projections that we have in the model are about people who have already agreed to start treatment and are doing so. So when we talk about greatly increasing the outreach, the enrollment, we're talking about reaching people who are much less willing to start treatment, either because they're distant from the facility or because of the kinds of really psychological reasons that Eva was describing. So what we need to do is model that additional cost. The upper left-hand quadrant of this graph shows what all of you will remember from your intro economics class. It's a downward sloping demand curve. If in fact there were prices for care, we know that the prices would ration the amount of utilization, and so the upper left quadrant shows exactly what you remember from micro. But of course we know that in South Africa today there are no prices. The prices are zero nominally, and so at a zero price, this is the sort of status quo right here in the middle, zero price, and this is the amount of patients that we're getting. If we want to have a lot more patients, it's going to mean a negative price. Now what does that mean? It means either paying a travel voucher, or it means actually doing the expenditure on the healthcare personnel and the counselors that Eva was describing. We're going to need to spend substantial money in order to get the numbers of additional patients that Dan and Anna predicted would be required in order to meet these various ambitious scenarios. How much more we're going to have to spend? We don't know the answer. And the blue, red, and yellow show 3 different hypotheses, with the blue curve representing a much smaller elasticity of demand, implying that we would have to spend a lot more to get the same number of patients. So we did sensitivity with respect to these various assumptions on the supply side, how elastic that cost curve is with respect to very small size facilities, and on the demand side with how elastic the demand would be. So these are the elasticities of demand. Another thing that you rarely hear talked about in great detail is the discount rate. The very famous paper by Ruben Granick and co-authors, including Brian Williams, used no discount rate, and therefore found very optimistic stories to tell, stories that no Minister of Finance would ever listen to, because he has to worry about the opportunity cost of money. And in fact, Ministers of Finance frequently attach quite high discount rates to decisions that they make. So we did the comparisons for various discount rates as well. This is what the 12 different scenarios look like with respect to total costs. Of course, this incorporates the cost savings due to the fact that treatment prevents HIV infection among partners. And the sexual model I haven't described, but that agent-based model also has lots of specifics about the infectivity and the suppression of infectiousness with effective treatment. So what you see in this model under a baseline set of assumptions is that red bar is exactly the cost of outreach, the extra cost of outreach that you have to incur under this set of assumptions in order to reach the numbers of people that are implied by these more ambitious scenarios. The yellow, the orange part, shows the change in the scale-dependent cost, the cost that would be lower if you only used very large facilities to deliver care, but expand substantially if you have to have lots of small facilities in order to reach all those people. Then we compare all of that. Last slide showed the total cost for 12 scenarios. This slide shows 11 comparisons, the comparisons between each of scenarios 2 through 12 to the baseline scenario, and divides those total costs by each of 2 units of benefits. One is the yellow gives you the incremental cost per incremental DALI averted, and the green gives you the cost per incremental HIV infection averted by each of these 2 strategies. And as you can see, the numbers are roughly correlated with one another. You should ignore this number, which is due to very small numbers being divided by one another, and it's not significant. But generally, you'll see that the cost per HIV infection averted varies from about $1,500 up to about $7,000. And then we can do various other things like this because of the fact that we have these detailed components of costs that come from the Clinton Health Access Initiative study, and also that come from the detailed cost modeling that Gesine has been doing for several years in South Africa. We can talk about the cost effectiveness, the cost per DALI, and break it out into the different components. And here you'll notice the red component is that outreach cost. It becomes a really substantial portion of the incremental cost when we go for the more ambitious scenarios. And just the last slide I want to show you is that I showed you those previous results slides for a specific for a specific chosen sort of central set of the elasticity assumptions and of the other assumptions in the model. But we're not at all certain about either the scale elasticity or the demand elasticity. In fact, I would think the thing that we're least certain about after hearing the presentations today is the demand elasticity. So depending on the demand elasticity that you get, the cost per additional DALI averted can be anywhere from the numbers that I was showing you down in the $300-400 number for some of these prioritized expansion scenarios, up to several thousands and even $10,000 or $15,000. So the parameters can matter a whole lot, and not only are they important, but just as Jorge described all the differences across Mexico, it's going to be true that in any country, the elasticity of demand is going to vary depending on the province, depending on income, education, depending on the road network, and these things have to be known in order to accurately project. One thing's for sure, and this is the note I'll end on, attempting to estimate the cost of scale-up by taking any constant number and multiplying it by the number of needed patients is bound to be misleading. And most ministers of finance know that, and they'll not listen much farther after you say that. So thank you very much.